Okay, so today we discuss a very important topic called preterm labor. It is an important topic not only for us in obstetrics, but also for our colleagues working in pediatrics and child health. We do know that babies are not supposed to come too early. Neither are they supposed to come too late, as in the case of postpartum pregnancy or indeed what we call post-death. So let's probably look at this particular topic. The outline for our presentation will be as follows. We'll look at definition of preterm labor, incidence, risk factors, so some bit of epidemiology. Then we'll look at prediction. If you can have a condition where you're able to predict, the better. But indeed, you can also prevent, especially if you're able to predict. Then we'll look at complications, we'll look at the clinical features of preterm labor, implying the symptoms and signs. Then we'll look at differential diagnosis, what might look like preterm labor when in fact it's not. And then we'll conclude by looking at the management. But I'll concentrate more on maternal, because I'm a midwife. The neonatal management of the baby born prematurely will be handled by our colleagues in pediatrics. So, we go. Definition. Now, basically this is labor occurring before 37 completed weeks. We know that what is defined as term is between 37 completed weeks to 40 completed weeks. So generally we are saying between 38 and 41. That's 10. But if labor comes before 37 completed weeks, meaning 37 plus 6, then it is referred to as preterm labor. Now suffice to mention that labor itself has to be defined because we are saying it's labor. What is labor? We know that labor is the onset of painful, regular, uterine contractions. Okay? Painful, regular uterine contractions, which, as we shall see in the clinical features, will explain why a lady will have intermittent lower abdominal pain. We'll explain later where the backache comes from and things like that. So it has to be that. Secondly, so the weight uterine contractions is crucial. But at the same time, it will be associated with progressive, not constant, but progressive cervical dilation. Plus another component, effacement. So the cervix has to start dilating, but at the same time there must be effacement. What is effacement? Effacement is the shortening and thinning of the cervix and its integration into the lower uterine segment. So a cervix of a non-pregnant woman looks like a tube. You can even put your finger around it and say the external os is closed. But the cervix of one who is pregnant becomes part of the uterus and it looks round as if there is a ring. No wonder you would say 2 centimeters, 4 centimeters, and so on, because it's shortened, it's thin, and it's part of the lower uterine segment. And here we can conclude and we say usually with the descent, not always, but descent of the presenting part. We know that in prime gravida, it's common that when labor starts, you tend to have the baby going down. But in a multi-gravida, you find that one will be 6 centimeters, but the head is still up at a descent of 5/5. So in conclusion, we are saying it's the onset of regular painful uterine contractions associated with progressive cervical dilatation and effacement, and usually with descent of the presenting part. That's how I would define labor myself. Now we are saying if this event occurs before 37 completed weeks, then it qualifies to be preterm labor. Now, there is some kind of classification, I didn't include it deliberately, where people would want to say preterm labor should be like very early preterm labor, early preterm, late preterm labor. Maybe those things are important for pediatricians. Like I know the physician, Dr. Kaunga, is a pediatrician. That's what she told me. She wants to do pediatrics and internal medicine both. So those people, I've seen them with a chart known as a Ballard score. So they are looking at the features of a preterm baby and they're trying to work backwards in retrospect to say, looking at where the ears are. How many creases are on the forehead? How many weeks could have this baby been born at? But I've never seen such things. So the classification for us on the obstetric part is inconsequential because it does not really change the direction of management. Let's go to incidence. So for incidence, we know that generally preterm labor incidence globally is about 9.9% to about 11%. Now, we know that this is not a hard and fast rule because you shall see later when you look at the risk factors that the incidence seems to be increasing because of iatrogenic causes of preterm labor. We ourselves are causing preterm labor, meaning that we are actually increasing the incidence. It's almost similar to multiple pregnancy. The incidence seems to be going up, as we shall see when we discuss multiple pregnancy later on today, that because of all this artificial reproductive or assisted reproductive technology and the use of ovulation induction agents, we see that the incidence of multiple pregnancy is going up. But generally, it could be around 9.9 to 11%. Now, more importantly, let's look at risk factors. Now, the most important risk factor which I want you to know and put a star on is previous history of preterm labor. Very serious risk, this one. Implying that one who has an episode of preterm labor might continue having the same as a recurrent problem. So a good nurse, a good midwife, a good clinician will be very, very mindful if they saw that mother, preferably, or couple, at preconception. Because they'll tell you, my first child was born at 32 weeks. I was even in NICU. And you are a clinician, you are a nurse. You need to tell them you have to see a practitioner at the hospital before you conceive next, because chances that it will come back is very high. That's one issue. The next is multiple pregnancy. We know that one of the complications of multiple pregnancy is preterm labor. And so, rarely are you going to have a triplet reaching 38 weeks. Even if it wanted to reach 38 weeks, we shall see later that we are discouraging that because the placenta becomes overwhelmed. There will be serious placental insufficiency. And you might end up losing all the babies in trying to keep them up to 10. So what do you do in that case? Again, if you deliver them too early, what happens? They will be too small to survive. So it means you have to strike a balance, not so. And I know Dr. Chulufia wants to do fetal-maternal obstetric medicine. So you can now objectively tell us, say, no, here we are right. Here, let's do this. Let's deliver at this point by this method. With some evidence, not by guesswork. Okay? But why are we talking about that? We shall see later. We'll discuss what's called selective reduction. Very bad procedure where you eliminate some of those babies so that you remain with only 2 or 3 out of the 7, so that you can increase the chances of those 3 as opposed to losing all of them at once. But that's a discussion for another day with a lot of ethical issues attached. Now, away from that, let's look at another problem, infections. Now, infections, we are talking mostly about lower genital tract infections, plus recurrent UTIs. We know that upper genital tract infections are not common in pregnancy because there's a mucus plug. So it's not possible to have PID in pregnancy because, mind you, you have a mucus plug, the baby is in membranes. So to have infection which will follow the deciduum and go to the tubes is unlikely, not so. If somebody told you, Dr. Mishpit, say this is PID in pregnancy at 8 weeks, what could come to your mind first as the likely diagnosis? 8 weeks, PID, acute PID. It's an ectopic pregnancy. So it means that somebody could have missed the diagnosis of an ectopic pregnancy because there's low abdominal pain, there could be signs of anemia, maybe minimal PV bleeding, but more importantly, when you examine, there will be some tenderness, and more importantly, possible cervical motion tenderness or cervical excitation, and that's chandelier sign. So you find some people would say PID in pregnancy, be suspicious of an ectopic. So, but lower genital tract infections are common. We are talking about bacterial vaginosis, we are talking about trichomoniasis, things like vaginal candidiasis. Those are infections that can precipitate preterm labor because they will irritate the prostaglandins, they will irritate oxytocin, and they bring back this process of labor onset. Clear? Yes. So all those cytokines become activated because of infection. Also, don't forget recurrent UTIs, Escherichia coli, and these friends can translocate from the urinary system into the reproductive system and cause that. Another problem is medical conditions. What conditions are we talking about? We know that top on the list we have anemia. We can also have conditions, of course, anemia goes with sickle cell disease. We can have kidney disease, including diabetes mellitus and so on. So several medical conditions can actually complicate into a preterm labor event. Don't forget also polyhydramnios. Don't also forget, now, in polyhydramnios, let me digress a bit. Polyhydramnios is excessive amniotic fluid in the amniotic cavity, but we know that it's a topic for its own. Is it diabetes? Is it that there is a placental sulfatase enzyme deficiency, or is it that we are dealing with an encephalite or some open urethritis? It's a topic on its own. But the point I'm trying to say is that avoid somebody who is polyhydramnios going into spontaneous labor. Because once the membranes rupture as a gush, what will happen? There will be cord prolapse or a cord accident, and there will be placental abruption. So to avoid that, we do what is called the stabilization induction with controlled ARM. What do we mean by stabilization induction? Once the membranes have opened maybe by 3 centimeters, either spontaneously because they've gone into preterm labor, as usually is the case, or by your own induction, then what you do is somebody goes abdominally to stabilize the head with the guide of an ultrasound to be sure that's the head, because they're at risk of unstable line. And then somebody goes in with the aid of a speculum to, under sterile condition, create a small puncture in the membranes. And once you create a small puncture using an amnio hook, or especially an amnio hook, it's a small thing, then you can put your finger there and release the fluid slowly as somebody remains stabilizing the head. Of course, issues of PPH prophylaxis and the rest and assessing the baby becomes important. What is the other problem that we have? We have uterine structural problems. What do we mean by uterine structural problems? Top on the list again is a submucosal uterine fibroid. Imagine you've got a fibroid within the space where the baby is supposed to be. Definitely the baby, it can be a problem. At the same time, cervical incompetence. Now when you refer back to our lectures, when we discussed miscarriages, we looked at recurrent miscarriages and we talked at cervical incompetence at great length. So just refer to that lecture in terms of cervical incompetence, but you know that it can be a problem because the cervix is part of the uterus. And then don't forget Mullerian problems as well. Make sure you remember the Mullerian ducts are the paramesonephric ducts. So if we have an issue in their embryology, you end up with a biconioid uterus or with the uterine didelphasis and other issues. Finally, not finally, we have, let me just call it lifestyle problems. Here I'm referring to smoking. I'm also referring to just poor nutrition. So basically, low socio-economic status can be a problem as well. Now, I've talked a lot about these risk factors which we have no much control over. But I'll draw a line and look at these two important ones. One of them is the ART. I'm not talking about highly active, is it called highly active? Antiretroviral therapy? Or combined, now it's called combined. But now we are talking about the assisted reproductive technology. So IVF and other forms of ART, which can be a discussion for another day, can be a problem. But at the same time, don't forget also complications of pregnancy. And this is where we become guilty as the obstetricians and the midwives, because we are the ones who create the preterm labor situation. How do we create it? If somebody has got preeclampsia, somebody has got cardiac disease and there is worsening New York heart status, or they've got diabetes mellitus, in most cases we start labor ourselves and come up with a preterm baby. We already have the patient, I won't mention the name, where we delivered at 34 weeks with a weight of 1.8 kg because that lady has a medical condition. Okay, but we created that situation because of that. So basically, that is it about the risk factors. There are many, but I think I've just highlighted what I consider to be most important. We are making progress. Let's go to prediction. Are we able to predict if somebody will have preterm labor or not? Yes. So the first way in which we can predict is by risk assessment. So some people have tried to come up with what are called the risk assessment scores. You know, scores are important in medicine when you want to put several aspects together. A good example is in pulmonary embolism. There is the modified World score, there is the Geneva score, there is the PEC score. All these are just scores to try to give you. Now, the problem with risk assessment scores is that their specificity and sensitivity is very low. It can just be a guide, but it should not be used in isolation. But what I mean is that if you take a history, so here is basically history taking. If you take a history and you find that your client has a lot of these risks, you can actually predict to say they are likely to develop preterm labor. That's one. Number two, there is use of transvaginal ultrasound. Transvaginal ultrasound, and at Cesare General Hospital, we can boast we have various probes on our machines, of our many several machines, more than 8, to see that you can use a probe vaginally and be able to check for two important things. The first thing that you are trying to check for is cervical length. And also patency of the internal cervical os. What do you mean by cervical length? The length we are interested in is not the length of the ectocervix, but it's the length of the endocervix. It's this length from here up to there. and not the one on the outside. This is the ecto, this is the endocervix. So now, this length, ideally, in a non-pregnant patient should not be less than 15 millimeters. So 1.5 centimeters. If you are not pregnant and your cervix is less than 15 millimeters, that's a risk. We can predict preterm labor. Or if one is pregnant, so non-pregnant. But if one is pregnant, it should not be less than 2 centimeters or 20 millimeters. Again, various authorities differ. Others even go up to 2.5. But I think 2 centimeters of the endocervical length, using a transvaginal, not an abdominal, but a transvaginal ultrasound, can be a strong predictor. But since this is not a postgraduate discussion, I will not talk about numbers in terms of specificity, sensitivity, and positive predictive values. But let's say generally, a cervix should not be less than 2 centimeters. That's one. Now, what about the patency? The patency is seen by the junction between the uterus and the cervix. There must be almost a 90-degree angle. It should not be like this. It should not come as an angle like that. This is called funneling. It's like a funnel. So if you've got a funnel and you've got a short cervix and you've got these risks, especially the first one, then you can predict that preterm labor is on its way. The second one, so this is 1, this is 2. The third one is by using what's called fetal fibronectin. What is fetal fibronectin? Fetal fibronectin is a glue which holds the blastocyst against, I don't have what to use to wrap up. If this is the blastocyst where implantation is happening, this is the part of the endometrial wall. The endometrium of a pregnant lady is not called an endometrium anymore, but it's called what? It's called the decidua. It's called a decidua. It's called decidua what? Is it capsularis, vera, or it's basalis, right? Since you answered incorrectly, I can increase the level of difficulty. Within the decidual basalis, what are the sub-layers? So, yes, you are very right. So this is the decidual basalis, and this is the blastocyst. The blastocyst wants to attach to the endometrial wall because this is an implantation process. Now, as implantation is occurring, it also has got stages if you go in embryology. But as the blastocyst is attaching here, it needs a glue, otherwise it will not hold. Before the chorionic villi starts forming, before all those processes we discussed under pre-eclampsia, in terms of what makes that interface. Now, we need the glue that will hold the blastocyst against the decidual basalis, particularly the chorion frondosum against the decidual basalis. Now, that glue is called the fetal fibronectin. It's a glycoprotein. Now, the normal level is about 2 to 4 grams per liter. Now, in early pregnancy, you expect the levels to rise because the implantation is still happening. So it means some of it will be leaking downwards into the vagina, not so. So when you get a swab here, you find that the fetal fibronectin level will be more than 4. But that should be in early pregnancy, like less than 16 weeks. But between 16 weeks and somewhere around 34 weeks, you are supposed to have almost 0, almost getting back to normal, less than 4. Other people just say less than 4. And then it again rises closer to labor onset. So you see that you can be using it as a predictor of preterm labor, because if you start getting high levels of fetal fibronectin in that range of preterm, then it can tell you that preterm labor is on its way in the next 7 days. That's when you can do as much interventions under prevention as you shall see as possible. But again, at postgraduate level, we are now talking about, has it got a stronger positive predictive value or a strong negative predictive value? Give me a guess. It has got a strong negative predictive value. It shouldn't even be a guess. A lot of you have done masters in public health and epidemiology. So you should be the one teaching me. So next, other than that, we've mentioned 3. The 4th one is the, let me just say other. So the most important one is history, meaning risk assessment score, transvaginal ultrasound for cervical length and patency, and then we talked about fetal fibronectin also. But there are some people who tried to use, for instance, vaginal pH. We know that the pH within the vagina is supposed to be acidic. So if it becomes alkaline, going by the pH scale, then you become suspicious. That's one, and therefore an alkaline vaginal environment is a predictor of preterm labor. And then there's also the use of AI. You know, in artificial intelligence, people have used, AI is a very strong tool because it cuts across all fields. Remember, we're just talking about history, risk assessment. Now imagine AI models are able to combine. So they will go into what are called metabolic panels of amniotic fluid and also electrohysterogram. Almost a combination of all those markers put together to give you a more closer risk, and so on and so forth. So there are many, but in most cases it's those 3. So that's prediction. Prevention. Are we able to prevent preterm labor? Maybe we can. Maybe we can't. So the first way to prevent, in my opinion, is you can only prevent something you know. So it means that it must be identification of risk. Why am I saying identification of risk? It's better you prevent preterm labor than when it starts. That's when you start firefighting it. Because we know that it's a spontaneous process that is not forgiving. Labor wants to start, you want to stop it. Is it possible that? Yeah? So let's identify the risk. Now, the second thing is that we need to consider cervical sacrilege. Now, cervical sacrilege, as we know, is usually applied between 14 and 16 weeks. Average for me is 15 weeks. I would like to place. We want to avoid the period of organogenesis, the first 3 months. At the same time, we don't want to do it very late. If you do it more than 16 weeks, we normally call it an emergency cervical sacrilege, or indeed we call it a rescue sacrilege. But the problem with the rescue sacrilege is that the membranes would have crossed the junction of the internal os. And when you're applying the sacrilege, you are supposed to aim for the internal os, because the weakness is at the level of the internal os. So if you try to do it without putting the patient in inverse transgenital position and without pushing the membranes backwards gently, you might find that you'll be forced to apply the sacrilege very distally. And that just becomes an academic exercise, and the patient will go into spontaneous miscarriage after the operation, and they'll be very upset with you. So don't do it too early, don't do it too late. I think that's the point that I'm trying to say. What are the methods of cervical sacrilege? We have the McDonald. We also have the Schrödinger, which has been phased out. But in the Schrödinger, we bury the suture, but in McDonald, now when I say McDonald, somebody then feels that. Because he has been to McDonald's, you know, he's been to the USA, that's what he was telling me that time. So in McDonald's, you're just putting a messenger tape around the cervix and tying it. Okay, so let's apply cervical sacrileges in these high-risk patients. Please, let's not be academic. No, I'm waiting for 3 miscarriages. That's when I'll apply. That is professional and academic in this field. Because every pregnancy is very important. So move books sometimes and look at the bigger picture. Away from cervical circlet, we know that progesterone, there is a form of progesterone which can prevent preterm labor. And so much research was done on it, known as the hydroxy progesterone calproate. So this type of progesterone is different from micronized progesterone, which we normally give progestat to prevent, like in a threatening miscarriage situation for corpus luteal support. This one, it is specific to prevent preterm labor, but I think the issues were what is the right gestational age to give it? What's the best formulation? And what's the best dosage? So I'll leave it that for those of you who like researching. But more importantly, let's be practical, things that you can do. Because if I told you, where can you find this type of progesterone? Can you find it? It's somewhere there, I know where you can find it. But then it's not commonly available. But let's look at what is more common. It is the active surveillance, or let me just say early detection plus treatment, even presumptively, of infection. Again, including subclinical infection. Similar to what we said when we discussed sickle cell, diabetes mellitus, and cardiac. These 3 conditions, sickle cell, diabetes, and cardiac. You don't want infection in a cardiac patient because the infection will go and sit on the valves. And according to Duke's criteria, there will be issues at majors and minors. You don't want infection in a sickler. It will push them towards a vaso-occlusive crisis. You don't want infection in a diabetic. It will cause hyperglycemia and risk the baby's certain IFP. You get the point? So it means that such a patient, every time they come for antenatal, do a urinalysis. If there are leukocytes, even if there is no dysuria, I would still give an antibiotic, presumptive, because I don't want infection at all. So that's what happens in these patients with high risk. Make sure that you give them an antibiotic. Make sure you do some screen, beat MCS, and give a good antibiotic. Clear? And that also goes with it. So here, we are not just talking about antibiotics, but also increase the hydration. We know that UTIs like an environment of dehydration. They are common in pregnancy because of issues with GFR, with the glucose, and also with progesterone. But still, if you don't take enough water, we know that the risk is increased. So let's deal with infection. Next, magnesium sulfate. Now, magnesium sulfate is not only used in obstetrics, just for treating and preventing eclampsia. We also use it for neuroprotection. What do we mean by neuroprotection? So the risk, now this is a neonatal benefit. The baby is born, risk of the baby developing cerebral palsy and those problems later on will be reduced if you give magnesium sulfate. But not in a regime we use for eclampsia or severe preeclampsia. What regimes are we using for preventing or treating eclampsia? It's the Preterm regime. But here, you find that we normally use the Zuspan. There are many regimes. That's why you are an obstetrician. You tell me the other 4. So there's the Dakar, there's the Sabai, there is many other types of regimes for giving magnesium sulfate. Yes, including the Sokota regimes. But mostly, I want you to go and look at the Zuspan regime. We find it to be very useful in other uses other than in hypertension. Let me put it that way. So just go and check Zuspan regime, magnesium sulfate. Now, away from that, we go to corticosteroids. Now, we know that in old books, we used to read books like 10 Teachers. Hope those are the books I read here. Okay, they are very good books. I just used to read 10 Teachers. But you find that people are saying, no, you only give corticosteroids between, how many weeks? 32 weeks, up to 34 weeks. I don't know if it was 28 up to, yes. So you give these corticosteroids to enhance fetal lung maturity. Now, what drugs are we talking about? We are talking about dexamethasone and betamethasone. These are corticosteroids. They are glucocorticoids in other words. We know that if it's in the adrenal cortex, they're coming from the zona what? Is it the reticularis? Is it the glomerulosa? Or the fasciculata? Back to basic science. Where do we get mineralocorticoids? Where do we get glucocorticoids? And where do we get the catecholamines? Now, these drugs, 2 minutes, I digress. For you to appreciate these drugs and how they work, we need to go back to certain basics, like surfactant. What makes surfactant? Okay, there are phospholipids and certain types of proteins. Number 2, we need to understand the stages of fetal lung maturity. Pseudoglandular, canalicular, whatever, alveolar, terminal sac, and so on. Next, we need to understand the cells in the lungs, the pneumocytes type 2, and the fact that these phospholipids are contained in what are called lamellar bodies, or osmophilic lamellar bodies. So that is a bit of basic science, because we need to understand these drugs. Why am I saying that? I'm saying that because the drug is injected on the mother, but the effect is on the baby. So definitely, even as a pharmacologist, you need to know that the drug, when it goes to the mother, should not remain on the mother's side. It should cross the placenta and go to the baby. Right? Yes. The question is, how much can the baby take? Now, if you look at dexamethasone, we normally give it at 6 gram BD/IM times 4 doses. What about the betamethasone, which is even better? Because 4 doses means that will be 2 days. This one may be 12 milligram BD/IM times 1 day, meaning 2 doses. Probably a big advantage, because it means if I'm so much constrained with time and I need to enhance fetal lung, you get the point, within 24 hours, this will be a better drug, but it's expensive. Now the question is, what are the advantages of these drugs to a preterm baby? One of it is to enhance fetal lung maturity. That's mostly the reason why we use it, to prevent respiratory distress syndrome, or formerly called hyaline membrane disease. But away from that, why else? It prevents the risk of intraventricular hemorrhage, and it also prevents the risk of necrotizing enterocolitis. Now these two, in fact all these 3 are complications of premature babies. So you find that corticosteroid is very important. Please colleagues, let's not have a preterm mother deliver without giving a chance to giving them a corticosteroid. If you are able to hold on a little bit on the risk-benefit scale and just give them a bit of steroids, please, I'll be very happy. Because you don't want the baby born and then 2 hours later failing to breathe, goes there, CPAP, and the prognosis becomes 50-50, when you could have done something. So basically, that is it about the corticosteroids under prevention. Next, tocolysis. Now, before I go to tocolysis, please, let's only repeat corticosteroids after a 2 weeks window. Let's not, every now and then, somebody starts some dexamethasone. Some dexamethasone. What will happen? What will be the risk? The risk is not even on the mother. The risk won't even be on the baby. It will be a neonatal risk. It will be seen much later as delayed psychomotor development. So don't use corticosteroids irrationally. And also, better still, they are even better used if you have evidence of fetal lung maturity by doing the tests. So instead of just guessing, no, let's give some DEXA. Ask him the fetal maternal, he will come. No, can we do lamellar body count? Can we do phosphatidylglycerol? Let's finish sphingomyelin ratio and call me back. Do even a form test, then call me back. You see, so there must be some evidence and not just doing things blind. Away from that, I've talked a lot about the corticosteroids because I'm trying to also cover other topics where we use this. Then let's look at tocolysis. Now, one of the big authorities we use in the obstetrics is the Royal College of Obstetrics and Gynecology. We use what are called the Green Top Guidelines. And those Green Top Guidelines tell us that the only indication for tocolysis based on evidence is two. One, it is to allow for action of corticosteroids. Remember, corticosteroids are for the time frame. So you want to hold on to labor so that the corticosteroids can work. That's one. The other one is in utero transfer. Imagine you are in a place like a health post and you've got a patient with severe preeclampsia at 30 weeks. You have magnesium sulfate, you have everything, you have antihypertensives. Then you deliver that patient by inducing labor. Then the baby is born at 1.4 kg. That's when you are looking for a transport, ambulance. Does that make sense? Why can't you move that premature baby in the uterus, in the womb? Now if you say womb, that's like saying this is a what? 0.5. This is a breastbone. Yeah? A windpipe. Yes, so we want the baby to move in the womb together with the mother. So it's called in utero transfer. It's nice to use such terms, right? We've received the referral from Konja, is it Konja? Or Milansolo, in the context of in utero transfer. Because they don't want to deliver and move. They want us to deliver here where we are closer to the NICU. So it's called in utero transfer. So during in utero transfer, you can use tocolysis. So I'm just mentioning that these are the only indications where I use tocolysis, not unnecessarily. Because I've seen some people using tocolysis even in threatening abortion. No, some bit of some Preterm. You'll feel better. There is no such indications. Okay, now what are the tocolysis that we have? With the permission of Dr. Chansa, can I digress? Because this is the main part. The rest of the part here is very complicated. Can I digress a bit? Not more than 5 minutes. Because I want to talk about the basic science. If you remember what happens, let's contrast a skeletal muscle with a smooth muscle. If you look at what happens in a skeletal muscle, this is what happens. There's something like that. So I'll be very quick. So you find that an action potential comes and hits the presynaptic membrane. And when it depolarizes the presynaptic membrane, what happens? What happens is that calcium, which is in the synaptic cleft, will jump and enter this side. And when calcium enters through this voltage gated channels, what will happen? So calcium seems to be a very important ion here. Then here you have what is called acetylcholine, which is stored in some vesicles. And what will those do? They will come here and release their contents by exocytosis. And where does this acetylcholine go? It will jump and come on this side, on the postsynaptic membrane, which is the motor end plate. Now it's excitatory in nature, so it will start creating some kind of electricity here. But those who, provided they don't reach the threshold potential, remember the O1 law. So they will just be summating, they're called by nature end plate potentials. And once the acetylcholine has done its job, by exciting here, what should happen is supposed to be destroyed by acetylcholine esterase, which is normally bound by the organophosphate poison, so that acetylcholine remains unopposed, just working continuously, leading to nicotinic and muscarinic effects. Anyway, back to my topic. So now, what will happen? This electricity which has been produced here will now move along the sarcolemma or the plasma membrane and dip into this. What are these called? T-tubules. Do you remember this term? And in the T tubules, what will you find? You'll find a certain gate here known as the dihydropyridine calcium receptor. So it will be activated. Now, once you activate the dihydropyridine calcium receptor, there will be another thing in the cell known as the endoplasmic reticulum, but it will be called the sarcoendoplasmic reticulum. So what will happen here again, the point, just follow what I'm following here, is the calcium. Again here there's calcium, a lot of calcium. So this calcium has just been stored and it has to come out and enter into the cell. On what gate? Is it going to be the dihydropyridine? No, it's the rhinodine. Forget the name. Ryan, not Ryan. This is an academic Ryan. Rhinodine. And where will the calcium go? It will now go on the contractile elements. Remember, there is what is called the tropomyosin. And there is troponin T, C, and I. So this calcium will sit on troponin C. And there will be conformational change, and that tropomyosin will move out and expose the actin binding sites. And then you will have now the myosin attaching to the actin there and forming what are called the cross bridges. There was such a thing in a book called Gano, right? For Guyton. Yes. Now, forget about everything I've written here. I'm just trying to contrast it with a smooth muscle, because you cannot talk about smooth muscles like the uterus without understanding the physiology. Now, for a smooth muscle, the difference, similar to this, but the difference is that a smooth muscle doesn't require electricity. All it requires, if this is a smooth muscle, is just to have enough calcium. Now the question is, where will the calcium come from if it's not going to come by this mechanism? So in your own time, go and look at one of the important pathways known as the CICR. Does anyone remember what it means? Calcium-induced calcium release. Then there is another pathway coming from what are called the second messenger pathways. Cyclic AMP, adenyl cyclase, P1, P2, IP3, or which is 1,4,5 triphosphate. That's what you are teaching me. Whichever the case, a lot of calcium. But now, what is funny about, now this is the point. What is funny about the calcium in a smooth muscle is that it doesn't go directly on the contractile elements, but it has to be linked to another chemical known as calmodulin. If you remember, to form what is called the calcium calmodulin complex. It's this calcium calmodulin complex which will activate what's called myosin light chain kinase and whatever, and that activation is what will now cause the cross bridges. In fact, they're called latch bridges. Why am I saying this? Oh, this is irrelevant. But one of the tocolytics we have are calcium channel blockers. But what an indirect way of explaining. So you can use nifedipine based on upsetting calcium. So you don't have calcium in the system. That's the point I'm trying to say. So back to my topic. I'm a midwife. So option number one under tocolytics, number one is the calcium channel blockers. And the top on the list here is nifedipine. But how do we give this nifedipine? Usually we would give maybe 30 milligram PO start and then maintain it at maybe 10 milligram TDS or even QID the oral. So that is the one option of suppressing uterine contractions. One option. The second option will be to use the beta-2 agonists. Now, please, let's not use salbutamol because of its effects. The best beta-2 agonist to consider is the, anyone can tell me? Tebuterine. You look at the dosages yourself, but tebuterine can be used. Now, why am I talking about beta-2 agonists? Again, it goes back to the second messengers I was talking about because of adenyl cyclase. Now we see why it's important to go back to those books, which we sold for a few pieces of silver, just to watch one game. You people who support the elephants. Then number 3, we can also have a drug known as magnesium sulfate. Do you know, whenever you see magnesium and calcium, they are like opposite friends. They compete, they've got the same valence. So no wonder you find magnesium sulfate toxicity, we use calcium gluconate. You know, again, magnesium and calcium. So that magnesium removes calcium out of and replaces. The 4th one is a drug called atosiban. Does anyone know how this drug works? Atosiban. Oh, atosiban. Atosiban is an oxytocin receptor antagonist. So it blocks oxytocin. Atosiban. Number 5, progesterone. Again, this has been tried. And number 6, there is what is called the nitric oxide donors. That is another option. So there are several tocolytics that you can consider in a preterm situation. Okay, so that is basically that. But before I conclude with prevention, also try to offset labor. Colleagues, let's not be too much in a hurry. Somebody has 30 weeks gestation and they are 2 centimeters dilated, even with some effacement. Because for me, there's absence of contraction. For me to be sure that this is labor, convince me that there are uterine contractions which can be palpable. Doesn't mean that the one who cries most has got strong contraction. You have to palpate with a stopwatch. Is it less than 20 seconds, 20 to 40, or more than 40 seconds? That's what I know. Number 2, you have to convince me that there is progressive cervical dilatation, and you also have to convince me that there is effacement. If any of these 3 is missing, then it's not labor. It's something else. Okay? So now, the point I'm trying to say is that even if it's established preterm labor, try not to be, you're even occupating, you're even making the process faster. There's a way in which you can try to suppress that kind of process. Sometimes it works, sometimes it does not work, but it can work, you know. And so how do we normally offset labor? Number 1, in my opinion, it's analgesia. So give a good analgesia, fentanyl or peptidine, provided the cervix is less than 7 centimeters, and you have some naloxone on standby. Number 2, hydration. And number 3, IV antibiotics. Number 4, a tocolytic, while you give a corticosteroid. So imagine you've got this cocktail in your labor ward, in early preterm labor. At least we will say that our testing which offsets this process, rather than you enhancing it and have a small baby that won't survive. But as you can see, prediction becomes more important and prevention than dealing with the process once it starts, because now you cannot predict. Away from that, we go to complications. Now, complications of preterm labor, can we leave it to the pediatricians? Yes, because I think pediatricians deal with the babies that have been born. But let me just highlight some of the problems. I think we've already talked about NEC, we've talked about IVH, we've talked about respiratory distress syndrome. But away from this, which are the other problems? We have prematurity, retinopathy of prematurity. Then there is also the at risk of neonatal jaundice stroke, maybe sepsis, I don't know. They are maybe at risk of cerebral palsy and things like that. So these are basically complications of preterm babies. Of course, there is also risk of hypothermia, hypoglycemia, and the rest. So I think I leave that for the pediatricians and for the neonatologists. But even you, as a person in labor ward, you have to be mindful. So if I don't manage my patient properly, the baby she's carrying might end up with these problems. And so it should always be at the back of our mind. Clinical features, I won't waste much time on clinical features because that is normal labor. We've already talked about, but we never discussed labor in this lecture. We said that it is in some document. But we all know, in terms of symptoms, that we talk about lower abdominal pains, intermittent lower abdominal pain with backache. We always try to ask for shock. We try to ask for draining. We even ask whether the mother is perceiving fetal movements. On examination, we've already talked about the fact that we need to see contractions. No, we can't see, but you can palpate. We need to check for cervical dilation plus effacement, and there must be some element of descent. Or as from the old school, we are using descent as a triangle. Descent, right? Something like that. So basically, and then we need to comment on whether the membranes are intact and so on, whether the position, the station, and the rest. So clinical features is not an issue. Let's look at differential diagnosis. Again, differential diagnosis is not an issue, but mostly what is confused to be preterm labor is urinary tract infection. I'm sure most of you have seen. Patient comes with UTI, and now the patient has been 2 centimeters from yesterday. Prolonged second stage. Oh, is it first stage? So let's even take for cesarean section at 28 weeks. Isn't that the academic in this case? Because it could just be a parascos. And somebody has a UTI because the bladder is in the same region as the uterus. So you can't use symptoms, just no abdominal pain equals labor. You have to have all those objective parameters to be sure that this is labor. Having taken a history and you look at the risk factors as well. The second thing is we could just be dealing with the Braxton-Hicks contractions, which we know some women tend to have them around 28 to 32 weeks, some bit of contraction. What else? We know that probably we could just be dealing with what's called round ligament pain. How does the round ligament pain manifest in a woman? She will have what are called side pains because of the course of the round ligament from the corner of the uterus to the labia majora. So if the progesterone levels in a woman falls, she will feel pain transmitted along the round ligaments. So those are some of the things you need to consider. Of course, if she has got fibroids, it could be red degeneration or cutaneous degeneration of fibroids. Quite common. It causes pain. Even small fibroids, one will outgrow their blood supply and the lady will have pain, and so on and so forth. So let's always think of differentials. Last, management.